Bismillah ar-Rahman ar-Rahim. Good day, everyone. I'm Dr. Mahmoud Sheikh, nephrology consultant and educator at World Kidney Academy. Today, we will be discussing this recently published review from NDT on the management of monoclonal gammopathy of renal significance, or what's called MGRS. MGRS is a very important topic because it sits at the intersection between nephrology and hematology and pathology and even the transplantation team. These patients often create significant diagnostic and management challenges because the kidney disease may be severe, while the hematologic clone itself may appear relatively small or even difficult to be detected. As a result, there is often uncertainty regarding when to biopsy, when to treat, which clone-directed therapy use, and how aggressive treatment should be. So in these articles, we will provide a very practical framework for approaching these difficult questions. So let's get started. Before we go deeper into the different pathologic patterns and treatments, let's us first understand what MGRS actually means. It stands for monoclonal gammopathy of renal significance. In simple terms, these patients have a small clone of abnormal B cells or plasma cells producing monoclonal immunoglobulin that is toxic to the kidney in different levels. The important part is that these patients don't meet the criteria for overt hematologic malignancies such as multiple myeloma or lymphoma. However, despite the relatively small clone burden, the kidney damage can be severe and progressive up to end-stage kidney disease. This is exactly why MGRS is different from MGUS, the previous entity. In MGUS, the monoclonal protein is usually considered clinically silent. In MGRS, the monoclonal protein is directly responsible for kidney injury. If untreated, this can lead to worsening proteinuria, chronic kidney disease, and end-stage kidney disease, and in many cases, recurrence after kidney transplantation. So because of that, the treatment goal is not simply observation. The real goal is to suppress or completely eradicate the pathogenic clone, even if it's small, in order to stop further monoclonal immunoglobulin production and the subsequent kidney damage. The better the hematologic response, especially if we achieve VGPR or better, the better the renal outcomes tend to be. One of the major challenges in MGRS is that sometimes we cannot easily detect the responsible clone. Sometimes patients have very subtle abnormalities on serum studies, bone marrow testing, or flow cytometry. That's why diagnosis and management often requires close collaboration between nephrology, hematology, pathology, and transplant, as we mentioned. So the key message here is simple: even there is a small monoclonal clone can cause major kidney damage in MGRS. The clone may be small, but renal consequences can be very significant and challenging and devastating. The next important question becomes who should be actually screened for it. In general, any patients older than 50 years with unexplained kidney dysfunction, glomerular disease, proteinuria, hematuria, or any declining kidney function should raise your suspicion. These patients should undergo screening for a monoclonal protein. The standard screening panel usually includes serum protein electrophoresis and urine protein electrophoresis, immunofixation, and serum-free light chain assay. Together, these tests increase the chance of detecting even very small clone. Importantly, even patients who already carry a diagnosis of MGS shouldn't even be ignored. At the time of MGS diagnosis, we should always obtain baseline serum creatinine, estimated GFR, and urine analysis. This is because some patients initially labeled as MGS may actually have underlying kidney involvement that has not yet been recognized. Once screening raises concern and the next major step, declining renal function, you will decide whether a kidney biopsy is needed or not. A biopsy is strongly advised when there is clear evidence of significant kidney injury. Examples include stage 3 acute kidney injury, progressive decline in kidney function, heavy proteinuria, or combined proteinuria and hematuria, or even Fanconi syndrome and tubulopathy signs. In these situations, the probability of clinically important renal involvement is high. Tissue diagnosis becomes very important. There is also patients in whom biopsy should at least be strongly considered, even if the findings are less dramatic. This includes milder AKI, moderate albuminuria despite preserved kidney function, hematuria with reduced systemic GFR, or evidence of light chain proteinuria. One very useful tool in this setting is the Mayo MGRS prediction tool. This tool helps estimate the likelihood of MGRS using several clinical variables. It can be very helpful in deciding which patients are more likely to benefit from kidney biopsy. So the overall message is simple here. If you have an older patients have an unexplained kidney abnormalities and evidence of monoclonal protein, we should always think seriously about MGRS. And in many cases, the kidney biopsy is what ultimately gives us the correct and perfect diagnosis. Once we decide that a kidney biopsy is needed, the biopsy itself has to be proceeded very carefully. An MGRS routine light microscopy alone is never enough. A complete evaluation requires light microscopy, immunofluorescence, and electron microscopy. Each of these techniques gives a different but complementary information. Light microscopy helps us identify pattern of injury. Immunofluorescence helps us determine whether there is monoclonal immunoglobulin deposition and whether there is a light chain or heavy chain restriction. And EM is often essential because it can reveal the exact ultrastructure pattern of deposits, including fibrillary, microtubular, crystalline, or organized deposits. Congo red staining should also be considered in any patients with a monoclonal protein because we always need to exclude amyloidosis, and this is the first step. In some cases, additional IgG subclass staining may be very helpful. This can confirm monotopic restriction and better define the type of monoclonal deposits. One important challenge is that sometimes deposits are present on EM, but immunofluorescence appears negative. This can happen in disorders such as C3 glomerulopathy with monoclonal gammopathy, light chain proximal tubulopathy, or crystal globulin-related disease. In these situations, repeating immunofluorescence or protease digestive paraffin-emitted tissue may reveal deposits that were missed initially. Beyond the kidney biopsy itself, that the patient also needs full hematologic workup. This usually includes serum urine monoclonal protein studies, bone marrow aspiration, biopsy, and flow cytometry. One newer technique that becoming increasingly important is multi-TOF mass spectrometry, which is very common these days in advanced centers like my clinic. This method is more sensitive than traditional immunofixation and can be better distinguish therapeutic antibodies from true endogenous monoclonal proteins. Some patients may still have no clearly detectable clone despite strong suspicion for MGRS. In these patients, additional testing such as CT scan, PET scan, peripheral blood flow cytometry may be needed at the time. Finally, we should not forget that some forms of MGRS are systemic disease. Conditions such as AL amyloidosis, monoclonal immunoglobulin deposition disease, cryoglobulinemic glomerulonephritis, and crystal storing histiocytosis can involve organs outside the kidney. So part of the evaluation should always include looking for extrarenal involvement. The main message is that diagnosing MGRS requires much more than simply identifying monoclonal protein. It requires detailed kidney pathology, careful hematologic testing, and MDT. MGRS is not a single disease, instead it's a group of different kidney lesions caused by monoclonal immunoglobulin. Each lesion has its own characteristic presentations, hematologic association, and patterns of monoclonal protein detection. And one of the most important and classic enteritis is AL amyloidosis. These patients usually present with nephrotic range proteinuria, often around 5 to 6 grams per day. Many patients also have nephrotic syndrome and significant extrarenal involvement affecting the liver, peripheral nerves. Monoclonal immunoglobulin deposition disease, or what's called MIDD, is another major entity. These patients often have proteinuria, chronic kidney disease, and hematuria. Unlike the amyloidosis, MIDD often causes more prominent decline in kidney function early in the process or course of the disease. Also, we have light chain proximal tubulopathy, or LCPT, and this has different presentation. This patient may have only modest proteinuria, but they often develops Fanconi syndrome, glycosuria, phosphaturia, proximal tubular dysfunction, and sometimes osteomalacia. PGN-MIDD, proliferative glomerulonephritis with monoclonal immunoglobulin deposition, usually presents with heavy proteinuria, nephrotic syndrome, and hematuria. One interesting feature is that monoclonal protein detection in the blood or urine may actually be low despite very active kidney disease. Also, we have cryoglobulinemic glomerulonephritis, especially type 1 and type 2. We present with proteinuria, hematuria, purpuric rash, neuropathy, and sometimes low complement levels, especially C4. Also, we have C3 glomerulopathy associated with monoclonal gammopathy, and another very important lesion. These patients often have hematuria, proteinuria, and low C3. In many cases, the monoclonal protein is highly detectable in serum studies. MGRS can also present as TMA. These patients may have hematuria, proteinuria, MAHA, low complement levels, and features of endothelial injury, hemolysis, low platelet count, and microangioplastic hemolytic anemia, as we mentioned. Another important point is that different lesions are linked to different hematologic conditions. Some are more commonly associated with plasma cell disorders, such as multiple myeloma. Others are more commonly linked to B-cell lymphomas or chronic lymphocytic leukemia. Also, the ability to detect monoclonal protein is not the same across all lesions. Some diseases, such as C3 glomerulopathy associated with monoclonal gammopathy, have a very high detection rate. Others, such as BGN-MID, may have very low rates of detectable monoclonal protein deposits clearly. So the key message here is that MGRS should all be thought as a spectrum of lesions rather than one single definite diagnosis. Understanding the specific lesion is very important because it guides both hematologic workup and the treatment strategy. Once the diagnosis of MGRS is confirmed, the cornerstone of treatment is clone-directed therapy. This is a very crucial step. The goal is not simply to treat the kidney manifestations. The real goal is to eliminate or suppress the pathogenic clone that is producing the nephrotoxic monoclonal immunoglobulin protein. The earlier we detect and treat, the better the chance of preserving kidney function and avoiding progressing to end-stage kidney damage. If treatment is delayed until severe chronic damage has already developed, the renal response becomes much more limited. In general, achieving a very good partial response or VGPR or an even deeper hematologic response is strongly associated with better kidney outcomes. That's why treatment should ideally begin before the estimated GFR falls below about 20 ml per minute per square meters. The exact treatment depends on the type of clone involved, and this process belongs to hematology. If the patient has B-cell clone or an IgM-related monoclonal protein, treatment is usually based on anti-CD20 therapies such as rituximab. On the other hand, if the patient has plasma cell clone or a non-IgM monoclonal protein, treatment is usually based on regimens such as bortezomib or daratumumab. In patients who already have very advanced kidney failure, especially with estimated GFR below 20, treatment decisions become more individualized. At this stage, therapy is often focused on patients who are candidates for kidney transplantation or those who have significant extrarenal involvement. In selected patients with MIDD or AL amyloidosis and high disease burden, autologous stem cell transplantation may also be considered. One important point is that these therapies can be complex and potentially toxic. They require close monitoring for infection and cytopenias, neuropathy, and other treatment-related complications. That's why MGRS management should always involve hematologists, oncologists, hematologists who are experienced with these treatment regimes or regimens. So the main message is simple here in MGRS. Treating the clone is the key to protect the progressing kidney impairment. Although the general principle is in MGRS is always clone-directed therapy, the exact treatment strategy differs depending on the specific lesions. For AL amyloidosis, for example, daratumumab-based therapy is now commonly used as first-line treatment. If daratumumab is not available, bortezomib-based regimens may remain a very good alternative. In eligible patients, autologous stem cell transplantation can also be considered. Monoclonal immunoglobulin deposition disease, MID, is also generally treated with clone-directed therapy. Daratumumab may be useful in refractory disease, and stem cell transplantation can be considered in selected patients. And for PG and MID, clone-directed therapy is also preferred whenever possible. If the clone is not clearly detectable, some patients may still benefit from empiric therapy. Immunomodulatory drugs may be considered as an alternative in certain situations. However, in patients with stable kidney function and mild disease, conservative management may sometimes be reasonable. In C3 glomerulopathy associated with monoclonal gammopathy, clone-directed therapy appears to produce better renal outcomes than immunosuppression alone. It's also important to think about genetic testing in these patients to exclude hereditary complement disorders. Cryoglobulinemic GN often requires both clone-directed therapy and immunosuppression. In severe disease, especially during IgM flares or rapidly progressing kidney injury, plasma exchange may also still be useful. These patients should also be advised to avoid cold exposure because this can trigger cryoglobulinemia-related symptoms. And light chain proximal tubulopathy has somewhat different approach. These patients usually receive cortisone-based therapy, but supportive care is also very important. Many patients need bicarbonate phosphate supplementation, active vitamin D, and treatment of Fanconi syndrome-related complications, which is the core of signs of the patient presentation. In monoclonal immunoglobulin-associated TME, treatment often includes clone-directed therapy together with plasma exchange, steroids, and rituximab. At the present time, there is very limited evidence supporting complement inhibitor in this setting. So even though all of these conditions fall under the umbrella of MGRS, each region has its own preferred treatment pathway. Understanding the specific pathology is what allows us to choose the right therapy for the right patients, which is precision medicine. After starting treatment, one of the most important questions becomes how do we know whether the patient is responding or not? In MGRS, we monitor both hematologic response and renal response. Hematologic response is especially important because deeper suppression of the clone is strongly associated with better kidney outcomes, as we mentioned before. For patients with AL amyloidosis, we usually use the ISA response criteria. A complete response, or CR, means negative immunofixation in both serum and urine together with normalization of the free light chain ratio. A very good practical response of VGPR means the difference between involved and uninvolved free light chains, or DFLC, falls below 40. Partial response, or PR, means there is more than a 50% reduction in DFLC compared with baseline. For patients with multiple myeloma-related lesions, we usually apply the IMWG response criteria. Stringent complete response, or CR, means complete response plus normal free light chain ratio and no evidence of clonal plasma cells in the bone marrow. Complete response means negative immunofixation in serum and urine, no plasmacytomas, and less than 5% plasma cells in the bone marrow. A very good partial response means that the monoclonal protein is detectable only by immunofixation, or there is more than 90% reduction in serum monoclonal protein. Partial response means more than 50% reduction in serum monoclonal protein together with major reduction in urine monoclonal protein. One practical point is that different MGRS lesions often use different response systems. In general, ISA amyloidosis criteria are more useful for glomerular lesions with proteinuria. On the other hand, IMWG criteria are often more useful for tubular lesions or lesions associated with plasma cell disorders. The key message here is that in MGRS, achieving deeper hematologic response is not just a laboratory goal. It's one of the strongest predictors of long-term renal survival. Once treatment has started, close follow-up is become very extremely important. During active treatment, patients are usually monitored every month. After disease becomes more stable, follow-up can often be spaced to every 3 months. At each visit, we usually repeat serum protein electrophoresis, immunofixation, serum free light change, kidney function, and urine studies, including the 24-hour protein urine immunofixation when needed. The reason for this close monitoring is that both hematologic clone and the kidney response may change over time. Some patients achieve rapid hematologic response but have only slow improvement in kidney function. Others may have stable initially but later show recurrent proteinuria or progressing decline in GFR. One of the strongest predictors on long-term renal response is that the amount of chronic damage already present on kidney biopsy. In particular, the degree of interstitial fibrosis and tubular atrophy, or IFTA, is very important. Patients with very mild or moderate EFTA tends to have much better chance of renal recovery compared with those who already have severe chronic scarring. Another important decision point comes around 6 months after starting treatment. If the patient has not achieved at least a very good partial remission or there is no meaningful renal response, then second-line therapy should be considered. In some cases, repeating the kidney biopsy may be still helpful. A repeat biopsy can help distinguishing whether the patient still have active monoclonal-related injury or whether most of the remaining disease is chronic irreversible scarring. Bone marrow reassessment may also be necessary, especially if there is concern for monoclonal evolution or resistance to therapy. One final point that MGRS is not always a stable condition. These patients have a higher risk of progression to overt hematologic malignancy compared with patients who have MGRS alone. The risk of progression is the highest during the early years after diagnosis. Because of that, patients with MGRS requires long life follow-up from both nephrology and hematology. So even after treatment is complete, continued monitoring remains very crucial and essential. In addition to clone-directed therapy, supportive clone is care is very important to these patients and a part of MGRS management. Many of these patients have hypertension, nephrotic syndrome, edema, orthostatic hypotension, or increased risk of thrombosis or even infection and sometimes bleeding. Blood pressure and fluid management are especially important. In patients with proteinuria and hypertension, ROS blockade can help reduce proteinuria and slow kidney disease progression. However, in patients with EL amyloidosis, these medications sometimes need to be used very carefully because orthostatic hypotension is very common. Regular monitoring of blood pressure, body weight, edema, and volume state is very important. Patients with fluid overload may need salt restriction, water restriction, and a diuretic therapy. In AL amyloidosis with severe orthostatic hypotension, some patients may also benefit from IV albumin, fludrocortisone, or midodrine. Another important thing that in patients with nephrotic syndrome proteinuria often have a higher thrombotic risk, especially if the serum albumin is below 3 grams per deciliter. The risk becomes even very high in patients receiving immunomodulatory drugs. In select high-risk patients, thromboprophylaxis may need to be considered. Infection prevention is also very essential in these patients because many of them receive immunosuppressive or clone-directed therapies. Vaccination status should be reviewed regularly from the start. Along the way, important vaccines include influenza, COVID-19, pneumococcal vaccination, Hep B, and herpes zoster vaccination when appropriate. The overall message is that successful management of MGRS is not only about suppressing the clone, it's also about protecting the patient from many complications that can develop along the way. Finally, let's talk about patients who progress to end-stage kidney disease and many could require kidney replacement therapy and kidney transplantation. Importantly, MGRS itself is not considered contraindication to kidney transplant. However, the major challenge is that recurrence after transplantation is very common, especially in patients with non-amyloidosis forms of MGRS. Some lesions can recur very quickly. For example, the light chain proximal tubulopathy may recur within only a few months. C3 GLUM-associated monoclonal gammopathy and PGN-MID can also recur relatively early after transplant. MIDD and AL amyloidosis may recur later, but still remain a significant risk. Because of this recurrence risk, proper hematologic control before transplantation is extremely important. In most patients, we aim to achieve at least a very good partial response or VGPR before proceeding with transplantation by enough time. This helps reduce the risk of early recurrence in the allograft. Once we achieve this, it will be very safe to proceed to transplantation. One exception may be select patient with AL amyloidosis because recurrence tends to be slower in some of these cases, and treatment may sometimes continue after the transplantation. Another important point is that once patients achieve VGPR, there is usually no specific waiting period required before transplantation. After transplant, close surveillance is very essential. Patients should continue regular monitoring of monoclonal protein levels, serum-free light chains, proteinuria and kidney function, and urine studies. Some disease, especially PGN-MID and MIDD, protocol biopsies may help identify recurrence before major kidney dysfunction can evolve. If recurrent or de novo MGRS develops in the transplant kidney, the treatment approach is generally similar to the approach used in the native kidney. So the key message is that kidney transplantation can absolutely be considered in MGRS. But the success of transplantation depends heavily on achieving good hematologic control before transplant and maintaining careful follow-ups afterward. This algorithm summarizes the overall approach to patients who have both chronic kidney disease and monoclonal gammopathy. One on the left side, we start with patients who already have known MGUS or when MGRS is strongly suspected. In these patients, the first step is to look carefully for any evidence of kidney involvement. That includes serum creatinine, estimate GFR, urine analysis, urine albumin to creatinine ratio, and quantification of the proteinuria. We should also look for metabolic clues such as low phosphate, metabolic acidosis, glycosuria, or uric acid abnormalities that might suggest Fanconi syndrome. Once the kidney involvement identified, the next question is whether a kidney biopsy is needed or not. Biopsy is strongly advised in patients with severe AKI, progressive decline in estimate GFR, or significant proteinuria with hematuria or Fanconi syndrome. In patients with milder abnormalities, biopsy should be still considered, especially if there is persistent albuminuria, hematuria, or light chain proteinuria. One exception is that patients with confirmed AL amyloidosis on a non-renal tissue biopsy and classic nephrotic presentation. In those cases, kidney biopsy may not always be necessary. On the right side of the algorithm, we start with patients who already have chronic kidney disease. The first step is to evaluate the likely causes of CKD. If there is an obvious consideration such as long-standing diabetes with a stable kidney function or only mild proteinuria, biopsy may not be very helpful. Similarly, in very frail patients with advanced age, severe comorbidities, or patients who are not transplant candidates, biopsy may offer limited benefit. On the other hand, biopsy becomes much more valuable when the cause of CKD is unclear. Examples include unexplained AKI, rapid decline in GFR, suspected GN, or patients with end-stage kidneys who are being considered for kidney transplantation. In cases where the risk and benefit maintain the uncertainty, additional lab evaluation for MGRS can help. This includes SPAP immunofixation, serum free light changes, UPAP, and urine immunofixation. The Mayo MGRS prediction scores may be also very helpful, guiding the decision. Ultimately, the kidney biopsy remains the key diagnostic step because it's what confirms the exact lesions and guides us to appropriate treatment strategy. These algorithms summarize how we approach treatment decisions in patients with MGRS, especially when the clone is not always clearly detectable. The first question is whether the patient is likely to benefit from active treatment. In general, clone-directed therapy should be considered if the patient has preserved kidney function, significant extrarenal involvement, or is being considered for kidney transplantation, as we mentioned before. On the other hand, if the patient has very advanced irreversible kidney disease without transplant plans and no major extrarenal involvement, conservative management may sometimes be more appropriate. If a detectable clone is identified, treatment becomes more straightforward. Plasma cell clones are generally treated with plasma cell-directed regimens. B-cell clones are generally treated with B-cell-directed regimens. The same concept applies when a monoclonal protein is detectable, even if clone can't be clearly identified. If the monoclonal protein is non-IgM, plasma cell-directed therapy is usually favored. If the monoclonal protein is IgM-related, B-cell-directed therapy is usually preferred. The more difficult situation is when there is no detectable clone and no detectable monoclonal protein. In these patients, the severity of kidney disease becomes very important. If the patient has more than 1 gram of proteinuria per day or progressive decline in kidney function, empiric clone-directed therapy should still be considered. In general, non-IgM variants may be treated with either plasma cell-directed or B-cell-directed therapy, depending on the overall clinical picture. IgM-related variants are more likely to benefit from B-cell-directed therapy. Light chain-only variants are more likely to respond to plasma cell-directed therapy. Immunomodulatory drugs may also be considered in some situations, especially when access to more specialized therapies is limited. On the other hand, if the patient has only mild proteinuria and stable kidney function, a period of conservative treatment with RAS blockade and close follow-up may be reasonable at that time. However, if the patient later develops worsening proteinuria or progressive decline in kidney function, then empiric clone-directed therapy should be considered. Across all of these different pathways, the overall treatment goals remain the same. We want to achieve at least a very good practical response, or VGPR, because this is strongly associated with the better long-term renal outcomes. Before we finish, it's important to mention that the field of MGRS is evolving very quickly. Several newer tools are helpful to improve screening and diagnosis and prediction of our patients' outcome. One of the most useful recent tools is the Mayo Clinic Prediction Tool. This model estimates the likelihood of MGRS using 8 clinical variables. It has very high sensitivity, especially when the lower threshold is used. This makes it particularly useful when deciding which patients may benefit from kidney biopsy. Another important area is the interpretation of serum free light chain in patients with chronic kidney disease, because kidney dysfunction itself raise free light chain level standard reference range may not always apply. The ISTOPMM study proposed modified reference ranges based on estimate GFR. For patients with estimate GFR between 45 and 59, the suggested free light chains ratio ranges about 0.4 to 2.6 and up to 3. For estimate GFR between 30 to 44, the range increased to about 0.4 to 3.38. And for the patient with estimate GFR below 30, the upper range may remain elevated up to around 3.5. Using the correct CT adjusted reference range is very important because it reduces false positive interpretations. There are also several new diagnostic techniques become very increasingly important. Heavy chain, light chain specific immunofluorescence can better distinguish monoclonal from polyclonal deposits. This can be particularly useful in diseases such as BGNMID and cryoglobulinemic glomerulonephritis. A multitude of mass effects is another promising technique. This is very sensitive than traditional immunofixation and can detect subtle abnormalities such as light chain glycosylation, which may be important in AL amyloidosis. Cytogenetics and FISH studies are also becoming increasingly relevant. For example, MID88 mutations can support the diagnosis of WM. The presence of T1114 may help identifying patients who are more likely to respond to BCL2 inhibitors such as venetoclax. So the key message is that modern MGRS care is becoming more precise, more individualized, and more dependent on advanced diagnostic tools. Finally, let's just briefly discuss some of the newest treatment developments in MGRS. One of the most important recent advances is daratumumab, which is anti-CD38 monoclonal antibody that has shown very impressive results, especially in AL amyloidosis, as we mentioned before. And the Andromeda trial, adding daratumumab to VCD, significantly improved hematologic and renal and cardiac response compared with standard therapy alone. Daratumumab is also showing promising results in another MGRS-related disease. It has demonstrated benefits in light chain deposition disease and BGN-MID, even in some patients with refractory behavior. Another interesting area is empiric clone-directed therapy. Traditionally, treatment was often delayed if we couldn't identify clear monoclonal protein or clonal population. However, emerging evidence suggests that patients can still benefit from empiric plasma cell-directed or B-cell-directed therapy, even when the clone is not clearly detectable. And many of these patients, empiric clone-directed therapies appear to produce much better outcome than non-specific immunosuppression alone. Another exciting area is the development of newer targeted treatment. Teclistamab is one example. This is bispecific T-cell engager that targets both BCMA and CD3. Early studies about relapsed refractory amyloidosis have shown rapid and deep hematologic response. Although these therapies are still early in developments for future MGRS treatments, so the overall message is that MGRS treatments is evolving rapidly. Newer therapies are becoming more targeted, more effective, and increasingly personalized based on the underlying clone and disease biology. To conclude, there are several very important messages to remember about MGRS. First, early recognition is absolutely critical. Any patient older than 50% with unexplained proteinuria, hematuria, declining kidney function, or glomerular disease should raise your suspicion. Early referral to nephrology, early investigation can prevent irreversible kidney damage. Second, kidney biopsy remains the foundation of any diagnosis. Even when monoclonal protein is detected, we still need tissue diagnosis to identify the exact lesion and to guide treatment. Advanced techniques such as protease digested paraffin immunofluorescence, IgG subclass staining, and multi-TOF mass spectrometry are making the diagnosis more accurate than ever before. Third, clone-directed therapy remains the standard of care. The main goal is to achieve at least a very good partial response, or VGPR, because deeper hematologic response are strongly associated with better renal outcomes. Newer therapies such as daratumumab are becoming increasingly important, and Embera clone-directed therapy may still be appropriate, even when a clone can't be clearly identified. Fourth, transplantation is possible in many patients with MGRS, but still requires very careful planning. Good hematological control before transplant is essential to reduce the risk of recurrence. Finally, MGRS requires lifelong follow-up. These patients remain at risk for recurrent kidney disease, clonal progression, and even transformation into overt hematologic malignancy. So successful MGRS management depends on not only on diagnosis and treatment, but also long-term MDT care. At the end, thank you so much for watching. I hope this topic has become much clearer and easier to approach. And always the key to mastering MGRS is to think early, biopsy early, and treatment the clone before irreversible kidney damage. See you in the next lecture. Assalamu alaikum wa rahmatullahi wa barakatuh.